Hello, this is Frank Gaillard from radiopeda.org, and today in the fourth part of our series on imaging of stroke, we'll be having a look at the temporal evolution of ischemic strokes. Before we start, let's have a look at three cases. Which of these do you think demonstrates the features of a chronic infarct? By the end of this video, the answer should hopefully be obvious. As we saw in our previous episode, the earliest visible sign is direct visualization of thromboembolism, seen here as a hyperdense middle cerebral artery. At this early stage, one struggles to make out even the earliest of parenchymal changes. Perhaps with the eye of faith, there is slight blurring and loss of grey-white matter interface of the lentiform nucleus and the insular cortex. If one were to perform an MRI, vivid restricted diffusion, bright on DWI with corresponding low signal on ADC, would be seen as in this scan from another patient. Going back to our previous patient, over the next couple of days the infarct becomes easily visible as a region of well-demarcated low attenuation, in this case with some areas of small hemorrhagic transformation. This is associated with swelling as extracellular and intracellular fluid accumulates. This is due to cellular swelling and breakdown of the blood-brain barrier. There is corresponding positive mass effect. Maximal swelling occurs during the first week, typically maximal at day 3 or so. In this case, swelling is so severe that a decompressive craniectomy is performed to try and alleviate raised intracranial pressure and herniation. With time, swelling starts to recede, as seen here on this day 11 scan. Note also how the reduced edema and associated influx of inflammatory cells histologically, the density of the infarct increases. This increase in density and reduction in swelling can in some patients almost exactly mimic normal brain during the second or third week following infarction, as is seen in this patient where the left-sided infarcts appear to vanish. This phenomenon is called fogging and is the focus of our next video. Note, however, that just because it appears normal on CT does not mean the stroke has resolved. Administration of contrast, either with CT or in this case MRI, easily demonstrates the region due to persistent breakdown of the blood-brain barrier resulting in leakage of contrast into the infarcted tissues. This is visualized as a region of gyriform cortical enhancement. Continued volume loss results in negative mass effect on the surrounding brain, seen here as ex-vacuo dilatation of the lateral ventricle, and continued decrease in the density approaching that of CSF. After a number of months, little change will occur with the region appearing as a focal loss of tissue, sometimes leaving a vague ghost of the previous gyral pattern, as seen in this patient, who had an infarct a number of years earlier. Note how all cerebral tissue in the region is lost, replaced by fluid, as demonstrated here, following CSF on all sequences including diffusion-weighted imaging and ADC maps. So if we go back and put all these CT images together, we can see a general pattern of evolution. The earliest parenchymal changes seen even a few hours after onset of ischemia is subtle loss of grey-white matter differentiation. Gradually over the next few days, the region becomes more defined and lower attenuating and swells such that the middle of the first week there is maximal swelling. After this, swelling gradually subsides and attenuation decreases, in some patients returning to near normal, so-called fogging phenomenon. Eventually the infarcted tissue is removed, leaving behind cystic encephalomalacia. It is important to note that the size of the infarct, therapeutic interventions and patient factors all influence exact timing. At either end of the process, the appearances and timing are predictable, but during the subacute phases, exact aging of an infarct can be difficult. Going back to our three cases, it should now be obvious that image A is of a chronic stroke. The region of infarction is very sharply demarcated and is of very low density, similar to that of CSF. And most importantly, there is negative mass effect with widening of the adjacent sulci and ex-vacuo dilatation of the lateral ventricle. In contrast, images B and C are subacute infarcts. They are often less well demarcated, especially early on, and although they are of lower attenuation than normal brain tissue, they are still very much denser than CSF. Most importantly, they have positive mass effect with effacement of the overlying sulci. In our next episode, we will go into the details of